Thank you. So I'm presenting a case on Miss W. She's a 34-year-old lady. She's UK-born of mixed race. She was diagnosed with HIV in '96. She's also co-infected with hepatitis C and has a detectable viral load. So she's previously been treated for pulmonary TB, fully sensitive, and comes into hospital quite frequently, recurrent chest infections, and was recently treated for a groin abscess with flucloxacillin. She's someone that's worked as a commercial sex worker, and until 6 weeks prior to her recent admission, she was actively injecting drugs, mostly into the groin. So as you can imagine, managing this patient's HIV infection wasn't very easy, given her social and medical background. Up until a few months ago, she had a detectable viral load and fairly low CD4 count. It's only now that we've got on top of her HIV control. So she initially presented to our A&E department on the 17th of October with a 2-week history of a swollen and painful right knee and ankle. She was seen by the A&E team and then seen by orthopods and admitted under the orthopedic team. So she was afebrile and hemodynamically stable on presentation, but she had a large, swollen, hot and tender right knee with reduced range of movement. Her right ankle, there was no significant swelling, just a mild tenderness. This was her x-ray of her right knee on presentation. We struggled, to be honest. So there's a large suprapatellar effusion, but the bony alignment joint spaces were all essentially normal. So the orthopedic etc. aspirated her knee on admission, and there was lots of thick yellow fluid. Gram stain was initially negative, but lots of pus cells were seen. In terms of inflammatory markers, her white cell counts were normal, but she had a raised CRP at 178. So the initial diagnosis on presentation was septic arthritis of the right knee. So what would you all do at this point? Would you commence her on empirical antimicrobials? Would you wait for the orthopods to do a surgical washout of that knee? Would you wait for cultures from the aspirate? Or would you do all of the above? Please cast your votes. So that's precisely what we did. We did do all of the above. So the next slide. So she was, like I said, she was admitted under the orthopods initially. She had her first washout of her knee the morning of her admission, and then required further 2 more washouts as clinically the knee wasn't improving. She was also started on oral fluconazole a few days into admission for oral candidiasis. She had further investigations to exclude a reactive arthritis, STI screen, blood cultures, stool cultures were all negative. Rheumatoid factor was just marginally raised, and the urate level was within normal range. Despite being on, so she'd been started on ceftriaxone further to microbiologist's advice, which orthopods had discussed with. But she hadn't improved being on 7 days on ceftriaxone, so she had an MRI of her right knee. So she basically, there was no signal abnormalities from the bone marrow, so this excluded osteomyelitis. But there was bony changes consistent with bony infarcts of the femoral condyle and the proximal tibia. And there's some synovitis. The synovium was quite bright. So the working diagnosis were chronic septic arthritis and avascular necrosis, so 2 separate diagnoses. So what would you do at this point? What would you think would be the causative organism of the septic arthritis? Please cast your votes. Glad you all said fungal, given the nature of this meeting, but I will move on and let you know what the diagnosis is. So she had 3 washouts. Samples were sent from the first and third washouts. We're not sure why the lab hadn't received anything from the second one, but yeast was isolated from these samples, including a synovial biopsy, and Candida albicans was cultured, which was fully sensitive. So we discussed this patient at our HIV MDT with our microbiologist, and the advice was to start on high-dose fluconazole, ideally at 800 milligrams. The patient was under the orthopedic team, and they increased the fluconazole to 400 milligrams IV once a day. It wasn't improving. She still had a swollen hot knee with a reduced range of movement. So we then had the patient transferred to our ward and increased the fluconazole to 800 milligrams IV once a day. So just a bit about septic arthritis in the context of HIV. It's relatively uncommon. There aren't that many reported cases of septic arthritis, particularly in the era of highly active antiretroviral therapy. The first published report of septic arthritis was in 1985, where sporotrichosis was identified in septic arthritis of the small joints of the hand. But the causative organisms are the same as those who are HIV negative, commonest being Staph aureus and strep. In terms of septic arthritis secondary to Candida albicans, again, very rarely reported, particularly in the area of heart. There's one published article from 91, a literature review, and Candida albicans was the third most common cause of septic arthritis, first being Staph aureus and second being mycobacterial infections. The route, so it's more common in IVDUs as you have a direct kind of blood-borne spread of the fungi. So this lady has two separate diagnoses. She has a chronic septic arthritis and she has an avascular necrosis. Just a brief summary about avascular necrosis. This is essentially bone death due to lack of blood supply. It can be idiopathic, but there are several secondary causes. This is just a snippet of few causes. Our patient has lots of these factors. Commonest cause are systemic corticosteroids. We believe our patient must have been given steroids when she had recurrent admissions with chest infections. It's also associated with antiretrovirals, particularly protease inhibitors. But given the fact that this is someone who's an intravenous drug user, who also has bilateral DVTs, she has HIV, these are all associated factors that probably attributed or contributed to her avascular necrosis. Avascular necrosis is increasing in our HIV population, particularly amongst our aging cohort of patients. As mentioned, there is an association with protease inhibitors, but our patients also have multiple comorbidities and they tend to be on lots of different drugs which can also be associated with avascular necrosis. And just briefly, bone disorders again is becoming quite common with our aging population of HIV patients. HIV in itself, through inflammatory markers, can cause loss of bone mineral density. The three most common bone disorders seen in HIV patients are osteonecrosis, also known as avascular necrosis, and osteopenia, where you have a low bone mineral density, and osteoporosis, where the bone resorption is greater than bone formation. So going back to our patient, despite being on 7 days of higher dose of fluconazole, clinically she hadn't improved. And this is a repeat MRI scan, and this was reported as showing progression of avascular necrosis. Once again, no evidence of osteomyelitis. So at this point, we weren't very sure whether this was septic arthritis because she wasn't started on the right dose of fluconazole. So at this point, we increased the fluconazole to an unlicensed dose of 500 milligrams BD orally. But the good thing was her beta-D-glucan levels had come down with fluconazole. I'm pleased to say that with 6 weeks of fluconazole, the patient's symptoms completely resolved. She was walking about with a good range of movement in her right knee. She's had repeat bloods taken this week for beta-D-glucan, so we're waiting for the results to come back. With regards to her avascular necrosis, we don't think this is just from her antiretroviral therapy. There's multiple factors that are associated with this, and at the moment she's under regular follow-up with the orthopedic team. So the learning points from, particularly for me, was this is the first time I'd ever seen Candida causing septic arthritis. And it's something to bear in mind in our kind of immunocompromised patients, high-risk patients who are injecting drug users. Appropriate dose of antifungals should have been started sooner on this patient, and bone disorders are something to consider with our aging HIV population. I'd just like to thank all my colleagues for their help with this case and with this presentation. Thank you.